So now I'll introduce Jackie. Jackie is a lecturer in occupational therapy at NUI Galway. She qualified as an occupational therapist from Trinity College Dublin, and she also completed her master's at Trinity as well. She's worked in various fields of mental health and within the HSE on community mental health teams and in inpatient units, carrying out a range of occupational therapy assessments and interventions. Jackie also worked for an assertive outreach team with high-risk individuals for the Department of Corrections in British Columbia in Canada. Jackie currently teaches mental health and group work to occupational therapy students, and in addition, she's completing her PhD on the topic of occupational therapy interventions for individuals with anxiety disorders, and her research interests include the impact of mental health difficulties on occupational performance and participation, and the exploration of evidence-based, occupation-focused interventions for mental health occupational therapists. So thank you very much, Jackie. Really looking forward to this webinar today, and I'll turn it over to you.
Okay, thank you very much. Can you hear me okay? So thank you very much for the opportunity to speak to you today. I'm just going to make that a little bit smaller. So as Nikita said, I'm going to be talking to you a little bit today about anxiety and stress in primary care, supporting recovery by redesigning daily life. And really, what my hope would be that by the end of this webinar that you would have an understanding of the prevalence of both anxiety disorders, but more what I'm going to be talking about is generalized stress in primary care. I'm going to be talking about the relationship between anxiety and stress and daily functioning. I'm going to talk a little bit about occupational therapy and where that might fit in. And I'm going to talk about this pilot study that I'm doing for my PhD, which is on an intervention called Redesigning Daily Occupations, some of the preliminary results. And then I'm going to end by talking about some self-management strategies that GPs could advise patients to do, and perhaps even look at some of the self-management strategies that we ourselves might be able to do to manage stress. Okay, so I suppose we know that anxiety disorders are highly prevalent. So across the EU, in the World Mental Health surveys, 7.8% of the population were diagnosed as having an anxiety disorder within the last 12 months. But really, I think general practitioners would feel that they're seeing patients in their practices with stress and anxiety symptoms in much larger numbers than this. So this is where I come to a multiple choice question for you. I hope you'll interact. So if you're thinking about your general practice in a primary care practice, what proportion of patients presenting with a physical health complaint do you think might also meet the criteria for anxiety or depression? So perhaps 9%, 19%, 29%, or 39%. So if you're thinking in primary care, what proportion of patients presenting with a physical health complaint could also meet the criteria for anxiety or depression? B, C. Okay, so one of each, B, C, and D. Thank you, everybody. Okay, so I suppose prevalence varies a little bit across the world, but certainly prevalence could be as high as 29% in primary care attendees. And this was in one US study, that 29% of patients coming in with a physical health complaint also met the diagnostic criteria for anxiety or depression. So really, the prevalence in primary care is very high. And the clinical presentation of anxiety or psychological distress in primary care is very complex because patients may not meet the diagnostic criteria for having an anxiety or mood disorder. And qualitative research with GPs would indicate that GPs can be reluctant to medicalize or diagnose what they and the patient feel are quite an understandable reaction to a stressful daily life circumstance. But nevertheless, this cohort of patients can be highly distressed and really having difficulty managing daily life as a result. And this prevalence is particularly high among the working age population, so the 18 to 65. One Swedish study surveyed nearly 600 general practice patients over 2 to 5 days. And of that nearly 600 patients, 60% said they felt stressed to to some extent, rather much, or very much. And of that 60%, 71% met the criteria for an anxiety disorder. So really, this is an extremely prevalent problem in primary care. And we also know that from the same WHO mental health surveys that anxiety consistently ranks in the top 10 most disabling conditions. In other words, that they are associated with a lot of difficulties functioning in daily life. So work functioning, household functioning, parenting, all of these normal tasks can be affected. Interestingly though, we know that difficulties with daily functioning and anxiety symptoms appear to be independent of each other. So in other words, poor daily functioning can continue even after anxiety symptoms recover. So even after maybe the panic attacks recover, poor daily functioning or not able to participate in daily life can continue. And the other side, we also know that losing interest and pleasure in daily life activities, so having anhedonia, we know that that can precede an anxiety or depression diagnosis by up to a year. So it's a risk factor that somebody is sliding into anxiety if they're starting to lose interest and pleasure in daily life. So interventions in primary care that focus on how individuals can manage daily life stressors and improve their participation in social work, community and home activities could play a role maybe in preventing the worsening of anxiety symptoms and maybe in maintaining recovery and wellness. And researchers now know, I suppose, that modern life has many hassles and stressors that are anxiety provoking. And perhaps that interventions that demedicalize symptoms and use self-management strategies can be very helpful. And this may be particularly where treatments such as cognitive behavioural therapy may not be so effective for somebody who has genuine stressors that mightn't be changeable by, changing the way you think about them as you would do if you were doing cognitive behavioural therapy. So in terms of treatment in primary care, studies with GPs would say that most GPs are taking a stepped care approach to the management of stress and anxiety in primary care. And really this is what is recommended in the NICE guidelines for the management of these conditions as well. Qualitative research with GPs would say that GPs often feel that anxiety symptoms can be a normal response to a stressful life event. And so we'll start by doing what's called watchful waiting. So offering support, but maybe no active treatment for several sessions, just to see if time itself might improve things. As part of my research, I've done some qualitative interviews with GPs. So we know that GPs are also offering lifestyle advice on, reducing caffeine and, increasing exercise, that kind of thing. And that they'll, recommend apps, online help, but will also then refer to private counselling, public counselling, maybe means-tested counselling. So evidence is varied really as to what kind of psychotherapeutic approach is better. And really it may well be that CBT suits some patients better, whereas something like behavioural activation might suit someone else better, particularly when somebody might have depression, a mixed depression and anxiety condition. For example, behavioural activation is often more indicated than CBT. So systematic reviews where these different psychological approaches are tested against each other tends to show that they all show some effectiveness, none particularly more so than another. The generic counselling available in primary care does also bring about improvement in mental health outcomes, according to one recent Cochrane review. And then, of course, there's the option of referring to psychiatric services. Now, there can be a level of dissatisfaction, I think, in Ireland with the treatment options available when a person is referred from primary care to the secondary care services. So one Irish study found that there can be a lack of communication back to the GP after a person is referred to the psychiatric services. And worryingly, in that study, 84% of the patients who were referred to the psychiatric services were seen only by a doctor in those services. So really they received no extra MDT involvement once they got into secondary care. So the bottom line, and this would seem to be supported by the NICE guidelines as well, is that really a range of treatment options need to be available in primary care, because some might suit some patients more than others. And the consensus would appear to be that group-based approaches and peer support approaches should be among the options offered in primary care. So, since the publication of Primary Care, A New Direction in 2001, the HSE document, there has been a greater focus on multidisciplinary primary care teams, and these have been rolled out, although the full multidisciplinary team might not be in place in all areas. And there's an understanding that in many places the numbers of staff are still too low to meet demand. Occupational therapists work as part of primary care teams across the country and are qualified to look at both mental and physical health issues for people. And because sometimes I think some people may not have come across occupational therapy before, the focus of occupational therapy is always on the improved participation of the person in the activities of daily life. And occupational therapists or OTs will use many different techniques, many different interventions, but essentially there's three main areas that they'll focus on, really regardless of the diagnosis of the person. So they might work on improving the environment for the person so that they can take part in daily living activities. So, for example, they might provide equipment or technology. They might help the person find social support. They might give advice on improving how the home is set up. They might work on improving the personal health of the person. So they might teach techniques to reduce stress, improve physical health or cognitive skills, or they might work on the occupations or the activities of daily life. So helping the person reorganize, grade, adapt, or learn how to take part in new activities. Because occupational therapists tend to carry out very individualized therapy, randomized controlled trials in this area are few and far between and are only beginning to be carried out. And any large-scale studies in the area of OT for mental health are particularly scarce. But again, we do know that behavioural approaches, so things like behavioural activation, where the focus of the intervention is on improving participation in productive activities, meaningful activities. So we do know that those kinds of interventions are being found to be equally as effective as cognitive behavioural therapy, at least when it comes to depression, according to some recent Cochrane reviews. So where does my study come in? I suppose my question was, is there an occupational therapy intervention out there that could meet this need in primary care, this high prevalence of anxiety and stress? And so I started with a systematic review. While there is very little research out there, there was a lot of very small studies out there. One intervention did come out as having the most potential to be implemented in this context, and that's called the Redesigning Daily Occupations program. So this program, and this is the program that I'm exploring in my PhD, so it was originally designed as a 16-week program in Sweden for women with stress and anxiety related conditions who are on stress-related sick leave from work. There is a 16-week version, as I said, but there is now a 10-week primary care version, and that's the version that I'm studying for this research project. So the program consists of 1 2-hour group session a week for 10 weeks, and then 2 follow-up group sessions a month apart at the end of that as well. So the focus of the Redesigning Daily Occupations program, or REDO, really the first 5 weeks look at self-analysis. So the concept of looking at how your daily activities are patterned, how they're organised, where they're balanced, where they're imbalanced. Women, the participants identify their own stressors, their triggers, the hassles that they have in daily life. And then towards the other half of the program, they start to move into goal setting, problem solving, making changes. And there is a lot of emphasis on the group support to making changes. There's some specific sessions around improving sleep and exercise, and I suppose throughout the whole program there's an emphasis on identifying your own personal activities that could be helpful for you, even in very small ways during your week. The program also has small pieces of therapeutic activity actually as part of the group. So for example, one session includes a craft activity, and that's very carefully chosen because number one, the group is trying to give participants an opportunity to take part in an enjoyable activity. And number two, use that experience to talk about how they could have more enjoyable activity in their week. So the PhD study is a feasibility study and a process evaluation of the Redesigning Daily Occupations programme for women with anxiety and stress in Irish primary care context. So really, I found this intervention, it seemed to be promising, but really we don't just dive straight into a randomised control trial, or certainly I couldn't do that. So a feasibility study is a type of study where you try to find out whether the intervention is acceptable, whether it can be rolled out in this context, whether it's even practical or useful in this context. I'm also carrying out a process evaluation, and a process evaluation is a way of understanding a complex intervention more than just in terms of its outcomes. So it looks at whether the programme was delivered as intended, whether it was delivered with fidelity, and it looks at contextual factors. So to see whether, try to discover what, if this programme works, why did it work? So you can see the research questions there, very much about, is this redo programme, is it acceptable to people? Does it have any trends towards effectiveness? How was it delivered? And if it worked, how does it work? So following ethical approval, this time last year, we recruited participants through 5 GP practices around Galway City and County with the help and support of the HRB Primary Care Clinical Trials Network. And we trained 8 occupational therapists in how to deliver the intervention, again with the support of the HSE Primary Care Occupational Therapy team. It was decided to just recruit women for this study for a couple of reasons. One, because of the higher numbers of women presenting with anxiety in primary care. That's one reason. Two, I suppose, with the recognition that group interventions tend to work a lot better when there are common issues in the group members. And three, because this redo intervention was originally designed based on research with women. So we felt we wanted to keep it very much, we didn't want to introduce any new elements to it at the feasibility stage. So we wanted to run a pilot randomised control trial with one group getting the redo programme and one group getting their GP care as usual. Unfortunately, and this would have been in autumn last year, this time last year, recruitment was slower than expected. So in the end, we just ran the redo programme with all the women who had expressed interest with no control group. And we used a lot of qualitative research and quantitative to gather all perspectives around that. So I carried out qualitative interviews with all of the participants, well, 5 out of 6 participants. I carried out qualitative interviews with all the GPs who referred to the programme, and also with the occupational therapists who facilitated it. And the occupational therapists also kept a reflective log for me, which helped me understand how the intervention was delivered with fidelity. So really, 6 participants is very small. It's not really enough to understand the intervention fully. So we've planned to recruit more widely for a second round of the programme to be held in Galway in spring 2019. And I'm going to talk a little bit more about further directions later on. But we will be planning on running another round of it in spring 2019 with both qualitative and quantitative data around that. So in terms of some preliminary results, there are very, very small numbers of participants in this study, and that's important to say. And because there's a lack of a control group, really doing any kind of hypothesis testing is inappropriate. But it is possible to look at some of the pre, post and follow-up outcome measures, and when it's combined with qualitative data, it does give a better idea of whether this program has the potential to be effective for this population. So 6 women completed the pre-intervention measures, and they're in red in the graph there in front of you. 5 completed them after the program, so that's in orange there, and 3 completed the follow-up measures, and those are in green. And it's important to say, as with any study, it's only possible to comment on the results of those who completed the measures. So those that didn't, might have been those that really didn't enjoy the program or those that didn't benefit from it. But 5 out of the 6 women did do comprehensive qualitative interviews as well. So that does help me understand, if it worked for some people, why, and if it didn't work for some people, why was that? So I used the Depression, Anxiety and Stress scale, which measures psychological distress, and this gives separate scores for both depression, anxiety and stress. So in terms of depression, at baseline you can see here 3 women were rated as having extremely severe depression. 1 rated as severe depression, 1 was mild and 1 rated as normal. Post-intervention in the orange there, 4 women fell within the range of normal. So the scores had fallen quite a bit. And in the graph above, just to explain to you, participant 6686 at the end there had post-intervention and follow-up scores of 0, which is why they're not appearing in the graph there. But you can see that the qualitative data helps us understand that a little bit more. That participants are saying that they're doing things that they weren't doing before the program. And as the second person there says, I did feel a massive shift in myself from start to the end. And I think you can see that in the quantitative results as well. So in terms of anxiety, at baseline, 4 women were rated as having extremely severe anxiety, 1 rated as moderate anxiety and 1 rated as normal. Post-intervention in the orange there, 3 women fell within the range of normal, 1 rated as moderate and 1 severe. And 1 participant had returned to moderate anxiety at follow-up. So you can see participant 2612 there had come back up in terms of anxiety scores in the follow-up. And again, last participant there in the diagram, participant 6686, had a follow-up score of 0. Again, the qualitative data helps us understand that a little bit more. People are saying, yes, I feel I can relax. Yeah, you're allowed. And the second person there saying that she pictured goals like a staircase, and that they were, instead of trying to reach the very, very top stair of the staircase, she just needed to set a small goal just for today, and that helped her. In terms of stress then at baseline, 1 woman was rated as having extremely severe stress at baseline, 2 severe stress, 2 moderate stress, and 1 rated as mild. So post-intervention in the orange, you can see that 4 women fell within the range of normal and 1 remained severe. So in these circumstances, you can see, and I focused on participant 5505 there as someone whose stress score did not go down very much over the course of the program. And the qualitative data helps understand why that might have been. So this is a participant who has autism, and while she found that she particularly wanted very concrete strategies out of the program, so things like setting goals. But when she did set her goals, she found that any deviation from those goals would cause her maybe more stress than somebody without autism. So that really helps understand when interventions might suit one person but might not suit somebody else. And it just, I think, provides some important context there. There's a lot on this slide, so I'm not going to read it all out, but part of the PhD study that I'm doing is also to explore whether this intervention is working as intended. In other words, whether the strategies actually result in changes to how daily activities are participated in. So the qualitative quotes here show a few examples of the kinds of daily life changes that the participants are talking about. So there were things like family changes. So particularly for the women that were mothers, they found that improving their own stress had a knock-on effect in the household. So if they were less stressed in the evenings, the children were also less stressed. A second one there is prioritizing self-care activities. So the second person there is talking about building in opportunities, even in a very busy life, for some self-care activity, whether that's a quick walk directly after dropping the children to school, or making time to read books or whatever, and prioritizing that kind of activity. The third one there, the participant is talking about doing one thing at a time. So many of the participants talked about running around, doing several things at once, trying to, I suppose, multitask all the time. But she found that just focusing on one task at a time with a time limit really helped her. So just saying, I'm just going to do laundry for half an hour, and when that's finished, I'll walk away from it. Okay, so she found she was able to be much more productive that way. The next one is about reducing social media use, and this came out from quite a number of participants, that constantly checking the phone, constantly having notifications coming in on the phone, or just spending a lot of quite wasted time looking at Facebook and things like that, really was disrupting daily life for them. So a couple of the participants, their goals were around reducing that. So the first person there has just turned off their notifications, and the second person actually turns off the phone entirely in the evening and doesn't turn it on again until the following morning. And then the last one there is about mindfully doing, and that's about taking part in activities without, I suppose, watching the clock. Just fully being immersed in the activity that you're doing without thinking about what's next or what's earlier or anything like that. And experiencing what is called flow, just enjoying an activity without worrying about what's coming next or watching the clock. So the focus on the Redo program is on redesigning daily life, doing one thing at a time, prioritizing valued activities, reducing interruptions. So this really does seem to be coming through in the changes that people are making. So exploring results like this, I think, really helps us to understand complex interventions, and it gives a good insight into whether the intervention is actually working as intended. So part of this study also included, like I said, doing qualitative interviews with GPs who refer to this program. So I know that GPs are already giving self-management advice to patients with anxiety or stress, whether that's about getting more sleep or doing more exercise or cutting down on working hours. And certainly sleep, cardiovascular exercise, and avoiding overwork are all really important evidence-based ways of improving anxiety and stress. For patients who are experiencing reactive stress and anxiety, or who have chaotic or rushed or stressful daily lives, or even who are underoccupied, who don't have very much meaningful daily activity in their lives, I'm just going to give a little bit more advice that could also add to, I suppose, your toolbox of strategies that you give to patients. So from the learning in this program and from research in the area, it could be helpful to advise patients that really their own daily activities have the potential to be redesigned so as to be restorative, to give value, to give meaning, and reduce stress. So can people look at their overall week, their overall month? What is there too much of at the moment in their life? Excuse me. Can they make choices? Can they prioritize? Can they say no? Can they delegate or get help for some things? And also, what is missing? Because often there is a whole swathe of important activities that are missing that make life enjoyable So we all need activities that are fun, that are playful, that help us let off steam, that are just enjoyable. In the same way that we also need activities that help us feel productive, and that challenge us and that give us an end result. And we also need activities that connect us. So they connect us to a community, maybe that connect us to our culture, connect us to family and friends. So this isn't about work-life balance, it's about balance across a whole range of areas in daily life. As we see, we know that cutting down on social media use can be helpful for reducing wasted time, and also from reducing pressure of just social comparison. Maybe setting limits on screen time could be something that could be suggested to patients. And just finally, thinking about doing activities one at a time. So we know that switching between activities, particularly activities relating to different roles. So say, for example, if you're checking work emails at the same time as trying to mind your children, that's cognitively very exhausting, and is a risk factor for stress. So setting limits to activities, doing one thing productively at a time can be helpful. The last thing to say, just in terms of advice for patients, is that in any psychosocial group-based intervention, a large piece of the therapeutic change is brought about just by the fact that it's a group. So in other words, just by being in a group where you feel like you belong, you trust other people, you have a common purpose, that's just as important as whatever the program or the intervention is supposed to be about. So those who have anxiety or stress in primary care might not want to attend therapy. They might not feel they have time, but really everybody needs to feel like they belong to some group network. For busy working people, they may find that in a workplace group, like a lunchtime walking group, a workplace choir. Parents could find it in a parent-toddler group or the Parents Association, something like that. Men particularly might find therapy groups particularly unattractive, but have they explored a men's shed or an active retirement group or tidy towns or an athletics club or other areas like that? So essentially encouraging somebody to join or connect with some helpful, healthy group network could be seen as almost like a prescription for anxiety or stress relief. The last thing to say really, I suppose, is this isn't just about the patients, the people that we see, but we know that levels of burnout among Irish GPs, while they are lower than comparative countries like the UK, they're still concerning. So in a recent survey, so 683 Irish GPs, nearly 53% were experiencing high levels of emotional exhaustion. So GPs also need to be looking after themselves, as I suppose do any of us in the workplace. So proactive or protective actions that you can take, they're exactly the same as what have already been talked about for our patients. Consider how daily life could be redesigned, maybe to spend more time with family and friends, preventing the creep of work into personal time, maybe reducing smartphones, social media use, but just building in moments of restorative activity in the working day. A brief walk, listening to music, just having an uninterrupted cup of coffee, whatever that is. And practices can look at the work environment and maybe, I suppose, look at the culture and make sure that the culture is accepting of people taking breaks, taking their lunch break, taking their holidays, and that there isn't unnecessary bureaucratic tasks. So future directions, if you're a GP, if you're based in the Galway city or nearby, if you'd like to refer patients from your practice to the Redo programme in spring 2019, keep an eye out with the HRB Clinical Trials Network, because they'll be looking for practices to take part once ethical approval has been granted. The other thing that's happening is that the HSE Occupational Therapy Department are considering running this programme at least once a year, if not twice a year, on an ongoing basis. And so you might be hearing from your occupational therapy services near you around Galway, looking for participants for those programs too. Okay, thank you very much for your attention. I want to just thank my academic supervisors, Agnes Shiel and Lena Karen Erlandson, and particularly the Primary Care Network, Clinical Trials Network, for helping me recruit for this trial, and to the occupational therapists who supported the programme and ran the programme for me. So thank you.
Thank you, Jackie. That was absolutely fascinating and incredibly topical and very promising as well. And I think certainly we can all take some advice from your webinar, so thanks very much. I have unmuted you there, or allowed you to unmute yourself if there's any burning questions. We might have time for one or two. If you want to just type it in the chat and I can ask it out then, and I'll just do a little bit of housekeeping. So, Andrew.
Hey, Jackie, thanks very much indeed for that, really helpful. And I know, because we did pilot it, how useful some of our patients found the service.
Okay.
It's the normal question now that we've sort of seen what it can do, and with the research not available for a while, is there a way that we can access for patients to sort of outline services currently? And is it, again, only for GMS eligible patients?
Well, I suppose the first thing to say is no, it's not just for medical card patients. It's for anybody. It's offered free as a public service, so there isn't any payment. But I had a meeting with the local occupational therapy manager, and what they're hoping to do is to carry out this program about twice a year in the Galway area. They're not going to open their waiting lists to everybody with anxiety and stress. They would be swamped. But if the program is running in September, they're going to put a call out to local primary care centres and say, look, we're going to be running this program in September. Can you send us some people specifically for this program? So that's their plan ongoing, that this redo program will be offered on a twice yearly basis around Galway, probably in Galway City.
Thank you.